I'm Susanna Campos, and I'm a medical oncologist at Dana-Farber Cancer Institute. And for the next 25 to 35 minutes, we're going to be talking about ovarian cancer, specifically how we construct pathways. So thank you for joining me. Today, we're going to be talking about practice-changing updates in ovarian cancer and its implications for pathway construction. I'm a medical oncologist, and this is my faculty disclosures, both AstraZeneca and Eisai. So the program information, I'd like to share with you some learning objectives. Hopefully by the end of our 35 minutes, we'll accomplish the 4 bullets that are here. We're going to differentiate the distinct pharmacokinetic, efficacy, and safety profiles of the PARP inhibitors. We're going to outline the latest approvals and clinical data informing the treatment of ovarian cancer. We're going to update guideline recommendations for real-world clinical experiences. And we're going to construct clinical pathways for ovarian cancer that support both evidence-based and individualized care. So thank you for joining me. So let's start by just talking a little bit about ovarian cancer and what makes it unique. In the American Cancer Society estimates for ovarian cancer in the United States, the literature suggests that in 2020, about 21,000 women will receive a new diagnosis of ovarian cancer, and about 14,000 women will die of ovarian cancer. Now, what are the unique features of ovarian cancer? Regrettably, in 2020, we do not have an effective screening test for ovarian cancer. And as such, most patients present with advanced stage 3 and stage 4 disease, making it a little bit difficult to keep people in remission. There are also numerous histological subtypes that may not respond equally to the backbone of chemotherapy, both carboplatin and Taxol. In addition, there are genomic aberrations that differ among the different histological subtypes. But more importantly, because of the advanced nature at presentation, we do a very nice job of putting patients into remission, but keeping people in remission becomes a bit of a more difficult task. Maintenance therapy, which we'll talk about extensively during our 35 minutes, has been studied for years. But there have been no maintenance therapies approved until recently, where the PARP inhibitors have shown us both a progression-free survival benefit and tolerability in the management of maintenance therapy. I think one important point to drive home is that, in years past, we used to do genetic screening for patients that were older, had ethnicities that were associated with the BRCA1 and BRCA2 mutation, or had a family history. At this point in time, and also through the guidelines of the American Society of Clinical Oncology meeting, all patients with ovarian cancer, regardless of age, ethnicity, or family history, should be screened for genetic aberrations, namely the BRCA1 and the BRCA2 mutation. Listed here on this slide is a nice synopsis published in the Journal of Clinical Oncology earlier this year by several physicians, which highlight really quite nicely the germline and somatic testing in epithelial ovarian cancer. And again, this paper published in JCO really does emphasize how extremely it is important, and you will understand this as we go along, how very important it is actually to test patients not only for a germline mutation, but also for a somatic mutation, as this has tremendous implications in how we manage patients with ovarian cancer. So let's start from the beginning. What is the upfront management of patients with ovarian cancer? As I mentioned earlier, regrettably, these patients often present with stage 3 and stage 4 disease. And as years have passed, we've continued to use the backbone of chemotherapy, carboplatin and Taxol. But we have looked at not only different schedules, but different routes of administration of these compounds. Carboplatin and Taxol can be given every 3 weeks. There's literature dating back 10 to 15 years regarding intraperitoneal chemotherapy with IP, cisplatin, and Taxol, actually showing a survival advantage in some studies. We've looked at weekly carboplatin and weekly Taxol, and we've looked at carboplatin given every 3 weeks and in conjunction with weekly Taxol. At the end of the day, despite the fact that there have been many studies and we've looked at all of these configurations, we've come back to the utilization of carboplatin and Taxol as the backbone of therapy for patients with ovarian cancer. Now, as I mentioned earlier, we do a very nice job of putting people into remission. Approximately 80% of patients who are treated with the backbone of carboplatin and Taxol achieve remission. What we aim to do is to keep them in remission, and that's become a harder task given the advanced nature of the disease that patients often present with. We also alluded earlier on that maintenance therapy, therapy after the induction therapy, has been studied extensively over the last decade, but it's only recently that this has gained momentum in that we have drugs that actually do improve the progression-free survival of patients with ovarian cancer. Now, if we go back probably about 5 to 10 years ago, the first drug that actually gained momentum was the use of a drug called Bevacizumab. Bevacizumab is a monoclonal antibody directed at the vascular endothelial growth factor. In these particular studies, we were aiming to improve progression-free survival in patients with advanced disease. On this slide is two pivotal trials, GOG 218 and also ICON 7. And as you can see from both of these studies, although there's similarities and yet there's some slight differences, patients were instructed and enrolled in studies that used carboplatin and Taxol as the backbone of therapy. But in some arms of the therapy, the addition of bevacizumab was added to the equation. And then in some arms, bevacizumab was maintained as maintenance. This occurred both in 218 and ICON 7. It's important to note that each study had slightly different eligibility criteria. And in the ICON 7, the dose of bevacizumab was 50% that of the GOG 218. The primary endpoint was progression-free survival. And as you can see from these particular curves in GOG 218, there was an improvement in progression-free survival with the use of bevacizumab. In this study, 17.3 months versus 12 months. In ICON 7, the benefit in progression-free survival was just simply not as robust. It was 19 months versus that of 17.3. When all was said and done, we knew that bevacizumab did improve progression-free survival, but regrettably, there was no overall survival. And it became obvious that bevacizumab really had a role in patients with ovarian cancer if, in essence, they were advanced cancers like stage 4, or if regrettably they had stage 3 cancer and they were not resectable. So in those high-risk individuals, for an example, an individual with ascites and pleural effusion or liver mets, the role of bevacizumab definitely did have a role, but in others, less so. So that was the first maintenance therapy to really gain momentum in patients with ovarian cancer. Now, on the heels of that, we directed our attention to that of DNA repair. So we repair DNA every single day. However, there's a specific repair mechanism that we utilize to repair double-stranded DNA breaks. And we call that homologous recombination deficiency, okay, or repair. So this homologous recombination repair is a DNA repair process that includes invasion of an undamaged DNA molecule by a damaged molecule of identical or similar sequence. This is an important mechanism to correct double-stranded DNA breaks because it tends to be error-free and it's quite reliable. Now, how do we weave homologous recombination deficiency into the world of maintenance therapy? Now, HRD is caused by alterations in homologous pathway genes. Now, we often talk about BRCAwt and BRCA2 as being a cause of not being able to repair your DNA by HRD. But there are many other genes that are actually also important in this pathway. And as you can see from this particular slide, I've highlighted BRCA1 and BRCA2, but there are many, many genes that, that when looked at, and if you have a deficiency in these genes, that you have difficulty in repairing your DNA by homologous recombination. RAD51, RAD51D, BARD1, ATM. So how is this important as maintenance therapy, and how do we link the concept of maintenance therapy for patients with ovarian cancer with HRD? So several years ago, there's been many studies that have looked at a particular group of drugs called the PARP inhibitors. Now, a PARP enzyme is an enzyme that helps correct DNA. An inhibitor inhibits that ability to correct that DNA. So if you take a look a little bit at this cartoon, we're linking here PARP inhibitors, with homologous recombination. Now, if one recalls that we have DNA breaks in all the time, and this creates single-stranded DNA breaks. And the PARPs, the enzymes, come in and they repair that damage through a process called base excision repair. However, if you inhibit the PARP by certain agents that we're going to describe, then these single-stranded DNA breaks, which normally would have been repaired by PARP enzymes, can no longer be repaired. And a single-stranded DNA break becomes a double-stranded DNA break, which becomes a little bit more of a complicated issue. Now going down the sequence, okay, if you have a normal cell, a cell that can repair its DNA by homologous recombination, the cell survives. However, if you have a cancer, let's say a ovarian cancer, that has an HRD deficiency, for example, a BRCA1 or BRCA2, that pathway is non-functional, and as such, in the process of a PARP inhibitor, the cell dies. So it's a clever mechanism to outsmart a cancer cell and kill the cell. Now the PARP inhibitors, there are 3 now that are FDA approved. One of them is called olaparib, one is called niraparib, and one of them is called rucaparib. And we'll talk a little bit about these and their indications, both in the upfront maintenance therapy in patients with ovarian cancer and also in the platinum-sensitive recurrent ovarian cancer. So the very first study that I'd like to bring to your attention is a very, very important study, and it's monumental. The SOLO-1 data asked a very important question. Specifically, in patients with ovarian peritoneal or fallopian tube cancer that were specifically either germline or somatic mutation carriers, whether or not we could improve progression-free survival if olaparib 300 milligrams BID was given to the patient. So the structure of the study is as such: newly diagnosed stage 3 or 4 patients with serous or endometrioid ovarian cancer, germline or somatic BRCA mutations, a good performance status. Patients received the backbone of chemotherapy with carboplatin and Taxol, and they had to be in a complete or partial response. Patients were subsequently randomized to olaparib at 300 milligrams BID in a 2-to-1 randomization format or placebo, and they were followed for approximately 2 years. The primary endpoint of the SOLO-1 study was progression-free survival. These are the results. The progression-free survival by the investigator assessment showed a very remarkable study. As you can see with the yellow curve, at 36 months, 3 years of follow-up, 60.4% of individuals were progression-free at 3 years. Compare and contrast that to placebo, which was approximately 27%. The hazard ratio was 0.30, which was statistically significant, highly statistically significant. The FDA approved olaparib for maintenance therapy in patients with both germline and somatic mutation. This particular study utilized olaparib. Now, as time passed, the question was, can we extend that benefit to all patients and simply not germline or somatic mutation carriers? The next study that evolved was called the PRIMA study, and this is a different study. First and foremost, the study drug here is niraparib, another PARP inhibitor. But in this particular case, this particular trial looked at patients that had pretty aggressive disease and had all comers. So it did not restrict itself, did not limit itself to germline or somatic mutations. As you can see, patients with newly diagnosed ovarian cancer at high risk for recurrence were given first-line therapy in a 2-to-1 randomization. They were randomized to either niraparib or placebo. However, all patients, regardless of BRCA mutation status or HRD, were able to be enrolled in this particular study. There were distinct eligibility criteria. The results of these studies was actually quite inviting. When one looks at the primary endpoint, that once again was progression-free survival in the overall population, all comers, the hazard ratio was 0.62. One can follow the blue line, which is niraparib versus placebo. When you look at the median progression-free survival, the median progression-free survival with niraparib as maintenance therapy was 13.8 months versus that of placebo, which was 8.2 months. That was a 38% reduction in the risk of relapse or death with niraparib, which was quite instrumental. Now, remember I mentioned that this was a study that was done in all comers. So the investigators looked at the progression-free survival benefit in subgroups of individuals. So they looked at patients that were HRD positive and HRD negative. So, for example, in the first graph here, we have HRD deficient, but you also had a BRCA mutation. And as you can see, those two curves separate very early on. And the hazard ratio is 0.40 with a rather tight confidence interval. The middle panel looks at HRD deficient individuals, but that had a wild-type BRCA mutation. So once again, we saw magnitude of benefit that was quite high. The hazard ratio was 0.50. Now, if we take a look at patients that were not BRCA mutation carriers and were not HRD deficient, but in essence, HR proficient, okay? One can see even though the curves actually align themselves more so than the other two, the hazard ratio is still less than 1 at 0.68, and this is statistically significant. So what the PRIMA data showed us is that the niraparib has activity as maintenance therapy in all comers. I think it's important to know that as these graphs show, that if you are a BRCA mutation carrier or if you're HRD positive, the magnitude of benefit is clearly higher than that of HRD proficient patients, but the benefit is indeed seen across all three groups, and the FDA approved this as such. Now, another study, a little bit of a different study, and is on the heels of our original slide using bevacizumab as maintenance therapy, was a phase 3 study called the PAOLA study. But this was a bit of a different design. The first-line therapy, this was first-line therapy in patients with ovarian, peritoneal, or fallopian tube cancer. Patients either had upfront surgery or interval debulking. The backbone of therapy was no different, it was paclitaxel and platinum. And patients in this case had to have greater than or equal to at least 3 cycles of the bevacizumab. If they were NED or in a complete or partial response, the patients were then randomized to olaparib, given twice daily for 2 years, plus bevacizumab, or placebo for 2 years, plus bevacizumab for 15 months. Primary endpoint was, like the others, the progression-free survival. Investigator assessed in this particular case. As you can see by these slides, this was the progression-free survival by HRd status. Let's take a look at the first graph. These were HRD positive individuals, but included patients that had a BRCA mutation. Once again, those curves separate quite nicely early on. We're looking at a hazard ratio of 0.33. The median progression-free survival was 37.2 months in patients that received the olaparib and the bevacizumab. Compared and contrast that with that of 17.7 months with the placebo and the bevacizumab. If we then turn our attention to the middle graph and look at HRD positive patients, but in this case, we're taking out those patients that had a BRCA mutation. Once again, those curves separate, okay? In this case, the hazard ratio is 0.43, and we're looking at a median progression-free survival of olaparib plus bevacizumab of 28.1 months versus that of 16.6 months. The third graph is that of the HRD proficient patients, and as you can see, the curves do superimpose on each other. The hazard ratio is not much different, it's 0.92, okay? It does cross 1, and if you look at the median progression-free survival, it's 16.9 versus 16.0 months. The FDA approved this combination specifically for patients with BRCA mutations and also patients that are HRD. HR proficient patients, the FDA did not grant this to an HR proficient patient. So it's important to actually understand the distinct differences and the eligibility criteria among these 3 studies. So I've presented to you 3. Solo 1 uses olaparib, PRIMA uses niraparib, and PAOLA uses both olaparib and bevacizumab. Now that is in the upfront maintenance therapy, and that has become standard of therapy. But this really got its start in the recurrent disease. When patients recur, if they recur greater than 6 months, we call and we note this as a platinum-sensitive recurrent ovarian cancer. If the disease returns at less than 6 months, we call them platinum-resistant ovarian cancer. The PARP inhibitors have activity as maintenance therapy in platinum-sensitive recurrent ovarian cancer. And if we go through the studies that actually have been published, these are the 4 pivotal trials. Study 19, which used olaparib, NOVA, which used niraparib, SOLO 2, which used olaparib, and the ARIEL 3 data, which used a third PARP inhibitor called rucaparib. So let's take a look a little bit about these studies and compare and contrast them. If one looks at platinum-sensitive maintenance in patients specifically that carry a BRCA mutation, and we look at Study 19, SOLO 2, NOVA, and ARIEL, we know that there's activity across all of these studies. Okay? We're looking at hazard ratios of 0.18 in the Study 19, 0.30 in SOLO 2, 0.27 in the NOVA study, and in the ARIEL study using rucaparib, a hazard ratio of 0.23. There's no doubt that one can improve progression-free survival in patients with platinum-sensitive recurrent ovarian cancer that have a mutation in the BRCA1 or 2 gene. Now, if we take a look in patients in this particular case, okay, that do not have a BRCA mutation, but they're wild type, Okay, and let's take a look at study 19, NOVA, and ARIEL-3. These three studies included patients that were wild type for BRCA mutation. And you can see in all of these three graphs, okay, that the hazard ratio is 0.54, 0.45, and 0.44. Once again, these PARP inhibitors, olaparib, niraparib, and rucaparib, even in patients that had a BRCA wild type, improved progression-free survival in platinum-sensitive recurrent ovarian cancer. Now, when take a look looks at the data in a different way and specifically divides the patient population into HR deficient or HR proficient individuals, and these are patients that are BRCA wild type again. If we take a look at the NOVA and the ARIEL-3 data, there's a hazard ratio of 0.38 with NOVA, which is niraparib, and a hazard ratio of 0.44 with ARIEL-3 in the HR deficient group of individuals. However, if you take a look also in the HR proficient individuals, both NOVA and ARIEL-3 have a hazard ratio of 0.58, which really suggests that these drugs, whether it be olaparib, niraparib, or rucaparib, have a role as maintenance therapy in patients with platinum-sensitive recurrent ovarian cancer. The FDA indication is for all three. All three are options in patients with recurrent platinum-sensitive ovarian cancer. So it's important to note that. I've quoted you several studies. However, each of these studies, whether it be SOLO 2, whether it be NOVA, whether it be Study 19 and ARIEL-3, they each had specific eligibility criteria, and some of the study designs were slightly different. So although we've grouped them here together because the message at the end of the day is they are all active, there is slight differences among these studies, and it's important to make note of that. So, in terms of the PARP inhibitors, we've talked about the PARP inhibitors in the upfront maintenance setting. We talked about SOLO 1, we talked about PRIMA, we talked about PAOLA. We talked about PARP inhibitors in the recurrent setting, platinum-sensitive ovarian cancer as maintenance therapy. We talked about Study 19, NOVA, we talked about SOLO 2, and we also talked about the ARIEL-3. Now, these are drugs. These are oral drugs. And it's important that we understand that every drug can be a rose, but every drug can have a thorn. So how do we appreciate the rose but avoid the thorns? We patrol the side effects of these particular agents so that when we actually do that, we have to anticipate, identify, we need to manage, and we need to mitigate the potential side effects of these drugs. Now, if we take a look at some of the first studies that I showed you, it's important to mention that some of these data actually overlap. There are some common toxicities among all of these PARP inhibitors, and there are some unique toxicities among a few. So this is some of the toxicity data from SOLO 1, which was upfront therapy as maintenance therapy. And as you can see, you can really think about the toxicities in terms of hematological toxicities. One can see anemia, we can see thrombocytopenia and leukopenia. Second toxicity is that of GI issues. It could be diarrhea, some vomiting, and nausea. And there are some less common side effects, for example, arthralgias and the like. But it's important to know that they were as we predicted, and we know that these are quite common, and we know how to mitigate some of these particular side effects. In a likewise fashion, when they looked at the PRIMA data, which used niraparib as the upfront maintenance therapy, there were no new signals. One of the main issues with niraparib has been in the past issues surrounding that of hematological toxicity, specifically that of thrombocytopenia. In some of the earlier studies, the NOVA data, they showed a high incidence of thrombocytopenia. But there's some recent data that suggests if one can attenuate the dose, and I'll show you some data, we can actually limit the adverse effects in terms of hematology. But this data from the PRIMA study shows us, once again, the signals, the toxicity associated with the PARP inhibitors is exactly what we'd expect. Hematological, GI, and others, and we'll get into that a bit more. Now, one thing that I mentioned was the fact that in the NOVA study, the original study, they did see a high incidence of thrombocytopenia. And this really asked the investigators to go back and look, who are these individuals who actually had a higher incidence of thrombocytopenia? So what the investigators did is they looked at a retrospective analysis to try to identify certain clinical parameters that would predict these dose reductions. Because in the original study, patients were dose reduced if they were going to be dose reduced from 300 to 200 early on. So they looked at two predictive factors. They looked at baseline weight and they looked at platelet count. And what was clear was that these were indeed risk factors for thrombocytopenia. So as it stands now, if a patient has a baseline weight of 77 kilograms or less, okay, or a platelet count less than 150,000, The starting dose should be modified to that of 200 milligrams every day and not 300 milligrams. So this is actually quite important. It's quite important to understand this, remember this, and execute this, because this really could mitigate the toxicity associated with niraparib. So it's actually quite important to make note, and I think it's been very helpful in the clinical practice. Now, one particular side effect that we paid close attention to, and is not unique to any one of these PARP inhibitors, is that of hematological toxicity, but specifically one in mind, and that is the risk of myelodysplastic syndrome that can lead to acute myelogenous leukemia. And this is the data from SOLO2, and this is updated data, and so the primary and final analyses. And you can see that the mean total duration of therapy. Initially, when this was reported at about 17.4 months, there were 4 cases of MDS. But as more follow-up occurred, 29.1 months, we saw an increased risk of MDS and AML. So this is actually quite important and quite intriguing, and it's quite important to actually look and see which patients might be more susceptible to developing MDS, which could lead to AML. A bit of a more of encouraging aspect is that looking at SOLO1, which is the upfront therapy in patients that were newly diagnosed with ovarian cancer at a median follow-up of 65 months, MDS AML occurred in only 1% of olaparib patients and no placebo patients. So more to come, but again, we always encourage all our clinicians and providers to really be cognizant of the fact that these agents, although rare, it can cause MDS and AML. Now, just to kind of put it all together, I mentioned to you that there were some common side effects, hematological and GI, but there are some unique side effects also. And here listed on this particular slide is just a description of some. We talked about GI. In terms of renal toxicity, you can see an increase in creatinine, mainly because it inhibits the MATE inhibitors with rucaparib. Fatigue is universal for all PARP inhibitors. Neurological patients can complain of headaches and insomnia. Respiratory issues, you can see a pneumonitis with olaparib. In terms of cardiac issues, hypertension, tachycardia has been described with the use of niraparib. In terms of skin toxicity, photosensitivity has been described with rucaparib. And muscle aches, namely arthralgias and back pain, have described with all PARP inhibitors. So in general, one thinks GI, one thinks anemia, but it's also important to be cognizant of the fact there are some unique toxicities so that you can micromanage this in your clinic. Now, we've talked about toxicity, but there's a different form of toxicity that I think is fair to actually broaden our knowledge of, and that is the financial toxicities. These drugs are not inexpensive drugs. And as you can look at this particular data, and this costs represent chemotherapy costs only. Calculations are based on a 70-year-old, 70 kilogram, someone with a creatinine of 1. And if one takes a look at the cost of the agents that we've described in our lecture, that we use in maintenance therapy, look at bevacizumab. Drug cost for 12 weeks is $32,000, niraparib $52,000, olaparib $45,000, and olaparib plus bev about $78,000. So when you use these drugs, we must be cognizant of the fact that they are indeed expensive drugs, so that when we advise patients to take these drugs as maintenance therapy, we have to be able to also manage their financial toxicity. And the companies have worked nicely with this. There are some assistance programs, and so this is manageable if one does one's homework, but it can be, and one should be cognizant of how expensive these drugs actually are. Now, I've talked to you about some similarities between these PARP inhibitors, and I group them as a whole together, the olaparib, the niraparib, and the rucaparib. But despite some commonality among these drugs, they are different drugs, and I would bring to the attention the issue regarding drug-to-drug interactions. And this slide is a nice slide that basically talks about the individual PARP inhibitors, but talks about the CYP enzymes used for metabolism, and this is quite important. So if one takes a look at olaparib, just for an example, the CYP3A4 is the enzyme that's used for metabolism. So one has to be very cognizant of the fact that there could be drug-to-drug interactions because the olaparib, the way it's metabolized, it inhibits the CYP3A4 and can induce the CYP2B6. So it's just quite important to understand how these drugs differ in terms of their metabolism. And if there is toxicity associated with these PARP inhibitors, it's quite important to understand how one modifies the dose. Now, in this particular slide, it talks about olaparib, the starting dose of 300 milligrams twice a day. First reduction is 250 twice a day. Second reduction is 200 BID. Niraparib starts off at 300 to 200 to 100, unless, of course, we go back to the platelets and weights, where you might be starting the dose at 200. And rucaparib starts off at 600 milligrams BID, goes down to 500 milligrams BID, 400, and then 300. In my own clinical practice, I tend to start off at a lower dose, and I escalate the dose so the patients can acclimate to the full dose, the full FDA-approved dose. Also gives me a slight indication how I can micromanage some of their side effects. So that is just a simple how-to do in terms of PARP dose modifications.
Good afternoon, everybody. It gives me an honor to talk to you today. My name is Alex Olawaye, and I come from the University of Pittsburgh, where I direct the gynecologic cancer research. I also happen to be the ovarian cancer pathway chair for the VIA pathway program. I want to start this talk by thanking you all for listening to this talk, and I want to express my appreciation to the organizers for inviting me to give the talk. Our topic, as you can see, is emerging therapies on the horizon for advanced ovarian cancer treatment. Here are my faculty disclosures. None impacts this talk. The first discussion that we're going to have is about the addition of veliparib to carboplatin and paclitaxel in women being treated for advanced ovarian cancer for the first time. This has been studied in this GOG 3005 study, which was a randomized phase 3 study led by Rob Coleman. And the study has now been published in the Journal of Medicine, New England Journal of Medicine, as you can see below. The study was done in 3 arms, and the randomization was 1-to-1 for all the 3 arms. Arm 1 was the control arm, where patients did not receive any veliparib. Arm 2 was the arm where the veliparib was only given during chemotherapy treatment, and there was no maintenance veliparib. In arm 3, the arm we refer to as the veliparib all through arm is the arm where veliparib was given with the combination of chemotherapy and also with transitioning to veliparib maintenance after chemotherapy was completed. It's important to note that veliparib was given at 150 milligrams twice a day during chemo in both arms 2 and 3, and it was given at 400 milligrams twice a day in arm 3. And this study is very important because, as you know, there are now 3 PARP inhibitor agents on the market for both treatment in the case of 2 of them, and for maintenance in all of the 3. And they are the olaparib, rucaparib, and niraparib. None of those agents is approved for combination with chemotherapy. You have to either use them on their own or use them after chemotherapy has been discontinued in the case of upfront therapy. This is the first phase 3 trial where a PARP inhibitor has been combined with chemotherapy successfully. The eligibility and stratification factors are those listed on the left side of the slide. After successfully completing the study, the curves shown here shows you the combination, the control arm in green, and the arm that got veliparib all through in purple. and this is in patients with BRCA mutation, germline BRCA mutation, and the progression-free survival in that group is approximately 35 months for those who received the active agent, veliparib, and the placebo group was 22 months. This was statistically significant with a hazard ratio of 0.44. In the group of patients with HRd, which is homologous recombination deficiency, which would include those patients that have germline mutation and the ones that had HRd confined to the cancer tissue. The performance of veliparib combination and maintenance was also superior to that of control as far as progression-free survival was concerned, given that active group 32 months versus 21 months in the control group. And again, the hazard ratio for this group is 0.57. And then the third group is the all-comer group, i.e. the intention to treat population. And this, again, the active arm of the trial consisting of veliparib combination versus, veliparib combination and maintenance versus control showed a statistically significant progression-free survival of approximately 24 months versus 17 months. The hazard ratio, as you can see, is 0.68. When arm 2 was compared with the control arm, and remember arm 2 was the veliparib combination only, where veliparib was given with chemotherapy and not given with as maintenance, the group did not perform better than the control arm of the study. As you can see, the green line overlaps with the deep blue line that represents the combination therapy arm. And the hazard ratio, which of course crossed 7, was 1.07. This medication, veliparib, has not been approved by the FDA, and it's probably this study is probably on the desk of the FDA being evaluated. I would now like to transition to this really exciting new approach to therapy that is called tumor treatment fields. Basically, in a very summarized form, this is using electrical fields to target cancer cells and kill them. And this is the first major study launched in the United States for this, and is the randomized open label study of tumor treatment fields with concomitant weekly Taxol in the treatment of recurrent ovarian cancer. Is also designated GOG 3029 or ENGOT OV50. A few words about tumor treatment fields. Tumor treatment fields are a non-invasive regional anti-mitotic treatment modality with minimal toxicity. Tumor treatment fields act by delivering low intensity, i.e. 1 to 3 volts per centimeter, intermediate frequency, again 100 to 300 kilohertz, alternating electric fields to the tumor using non-invasive transducer arrays placed on the skin around the region of the body containing the tumor. Tumor treatment fields act predominantly during 2 phases of mitosis. In metaphase, it disrupts the formation of mitotic spindles, and also during cytokinesis, which is telophase, it causes dielectrophoretic dislocation of intracellular constituents, resulting in apoptosis. What that simply means is once the mitosis is about to complete and the two daughter cells are being formed, the distribution of cellular content become uneven because those cellular contents are being, their distribution is being affected by the electrical fields to which they're being subjected. It has been approved for the treatment of recurrent and newly diagnosed glioblastoma multiforme. And this, in fact, is one very encouraging factor because that's a very difficult disease to treat, as all of you can appreciate. And also important to note that the intermediate frequency that was used for the treatment of glioblastoma multiforme in all the studies, and that's been approved, is actually 200 kilohertz. And that is relevant because that is exact same intermediate frequency that has been found to be applicable to ovarian cancer. There is a pilot study which has been completed and published, and this is the INNOVATE study that was a prospective pilot clinical trial testing the safety and preliminary efficacy of tumor treatment fields, 200 kilohertz, as I mentioned earlier, with concomitant weekly paclitaxel for recurrent ovarian cancer. This study was a single-arm study that enrolled 31 patients. Of note is the fact that none of the side effects or adverse events that were seen on this trial was related to tumor treatment fields in such a way that it had to be discontinued. The average patient on the trial had been treated with 4 lines of therapy, and therefore this was a very heavily pretreated population of patients. And the graph or curve on the left shows the overall survival curve, and actually that has not been reached as of the time of the publication, and the progression-free survival was 8.9 months. And if you look at the details of the trial, the response rate was in excess of 25%, and another 46% of the patients experienced stable disease, and therefore the total clinical benefit rate in this small pilot study was 71%, which was very impressive. And now I would like to transition to another treatment approach that is hopefully going to see daylight in the future. And this is a treatment approach that is called the M-TRAP. And honestly speaking, that really captures this treatment approach. It's about trapping cancer cells. Is exosome-based capture of tumor cells as a new technology in peritoneal metastasis. Metastasis represents the most devastating event in oncology, and that really is the executive summary, because cancer that has not metastasized is very easy to treat, and we achieve very high cure rates for those cancers. Cancer metastasis is responsible for more than 90% of cancer-related deaths, and successful establishment of metastasis is the result of a very intense dialogue between the primary tumors and their environment. This is a new discovery, a novel approach in oncology that disrupts the process of metastasis by interfering with this intense dialogue between the primary tumor site and potential metastatic sites would be transformative for cancer therapy, especially intra-abdominal cancer, such as ovarian cancer. Recent work in melanoma discovered that exosomes, a subset of microvesicles involved in the transfer of information, are a mode of cellular communication, and exosomes can be isolated and purified, thus offering a therapeutic modality that can be utilized, hopefully, in clinical medicine. So in this preclinical experiment, which is really fascinating, exosomes at a concentration of 2 micrograms per microliter were embedded into 3D insert scaffolds, which are called M-trap. And an in vivo experiment utilized 3 groups of mice to look at the effect or the efficacy of using the M-trap. In group 1, the control group, the mice were intraperitoneally injected with 2.5 times 10 to the power of 6 luciferase expressing SKOV3 cells and followed up. SKOV3 cells, for those who may not be familiar with it, these are just cell lines. They are developed, they are ovarian cancer cell lines. And in group 2, a similar volume concentration of cells were injected into the second group of mice intraperitoneally, and but a week before that was done, the device that we described before, the M-trap device, had been implanted into the peritoneal cavity of the mice ahead of the cancer cell injection. And lastly, in group 3, they're very similar to group 2. So they also had the M-trap device inserted into the peritoneal cavity a week ahead of injecting them with the cancer cell line. And then after some time, after 1 month to be specific, the group 3 mice were operated on and the M-trap device was removed. And see what happened. So in control group, group 1, the mice did not live very long, and they are represented by the darkest line there. And as you can see, in a little over 100 days, all of the mice in that group had died of their peritoneal carcinomatosis. In group 2, where the M-trap device was inserted and not removed, the mice lived slightly longer, but again, in approximately 250 days, those mice eventually died. If you look at group 3, where the M-trap was inserted ahead of the cancer cell injection and then removed subsequently after 1 month, those mice, as of the termination of the experiment, many of them had continued to live, showing the efficacy of the M-trap device. If you look at the group 1 mice dissection, they had extensive carcinomatosis, and that is what is lighting up by bioluminescence in the mouse that is being shown here, because the M-trap device was not inserted into this animal. In the second group, where the M-trap device was inserted but not removed, it was interesting, or I should say fascinating, because the peritoneal carcinomatosis that we just saw in group 1 had been focalized in group 2. So the cancer cells were there, but they were concentrated and trapped in the M-trap device. And as you can see, the bioluminescence picture did not show anything lighting up in the general peritoneal cavity. All that lighted up was confined to the area of the M-trap device. And if you look at the last group, which was where the animals were reoperated and the device was removed, that group, the bioluminescence was totally failed to light up because there were no detectable cancer cells in the peritoneal cavity of those group 3 animals. And this obviously has to be taken from the bench to the clinic. There is a need for large animal research into this, and then subsequently, hopefully, it would see the first human studies and become part of what we incorporate into the clinical treatment of advanced ovarian cancer. Thank you.
Now, all of this data, where do we place it? Okay, at the end of the day, these are wonderful graphs. They're very pretty. They show us very encouraging data. But how to bring this data to patients? How do we construct pathways so as a clinician, okay, one can delegate the correct drug, the appropriate drug to an individual who has ovarian cancer, who has responded to that of induction therapy. So in this part, this is actually quite important. We start off by understanding the literature, and I think that's what we've done for the last 20-25 minutes. We've talked about SOLO-1, we've talked about PRIMA, we've talked about the PAOLA data, we've talked about recurrent ovarian cancer, and we've talked about the toxicities, including financial toxicity. How do we put this together such that we create a pathway, an algorithm, a blueprint for clinicians to treat patients with recurrent ovarian cancer? So what I've actually outlined is, how do we look through a clinician's eye? Because these studies include thousands of patients, but the truth is the patients that we see in our clinic may not always mirror the patients that were enrolled in this clinical study. And yet we need to use the data that we've just described and micromanage it so that we can apply it to the patient that sits before it. So we need to look through a clinician's lens. So let's start at the beginning. I started at the beginning talking to you about some of the different trials. And as you could probably guess, some of the different trials actually incorporated Bev and some did not. So when we created an algorithm to update our profile for patients with ovarian cancer, the first bullet, the clinical decision analysis was, did the patient receive Bev or did the patient not receive bevacizumab? Now, within the context of that, let's say they considered Bev, you considered Bev for this patient, you started bevacizumab up front with patients with recurrent ovarian cancer. The second question is, what about the genomic aberrations? Are they a BRCA mutation carrier, whether it be a germline or somatic? Remember, we mentioned that it's extremely important to test people up front. Does this patient have an HRd deficiency? Okay, HRd deficiency can be measured in two ways. There's a Myriad test and there's a Foundation Medicine test. Or is the patient a BRCA wild type and HRd negative? So if you started off with Bev, how do you delegate maintenance therapy in these three categories of individuals? Because these are the patients that you will see in your clinic. The second bullet is no Bev. What if we didn't start with bevacizumab, okay? Well, then we take into consideration, is this a BRCA mutation carrier, whether it be a germline or somatic? Is the patient HRd positive? Is the patient a BRCA wild type or HRd negative? So how do we navigate this? So we lean on data. We decide on Bev at the time 0. How? We look to GOG 218, we look to ICON 7, and we select those patients that we think bevacizumab would be instrumental in. And we talked about this. We talked about bevacizumab in terms of patients with stage 4 disease, ascites, pleural effusions, liver mets. We talked about advanced stage 3C patients that are not resectable. These are patients that we tend to lean towards Bev. So if we choose to incorporate that into the algorithm, okay, we lean on the studies that I've just described. So let's create a pathway in our head at this point in time. So let's start off with, you've made a decision for bevacizumab to be employed in the use of the micromanagement of your patients. We then looked at genomic alterations. So what are the choices for patients as maintenance therapy, and what is the literature that we lean on to support our decision? So we started off with one decision. We've used bevacizumab. Now, we look at genomic alterations. If the person had a germline mutation or a somatic mutation in the BRCA mutation, there are several choices. We could pick olaparib as a maintenance therapy, and this is based on the SOLO-1 data. We can choose olaparib plus bevacizumab, and that's based on the PAOLA data, or we could choose niraparib based on the PRIMA data. Now, in contrast, if the person was not a BRCA mutation carrier, but a BRCA wild type, but was HRd positive, okay, what would be the options available as we're building our platform, as we're building our clinical pathway? Well, if they started off with Bev, they could have olaparib and bevacizumab, and that is based on the PAOLA trial. They could also have been given niraparib, and that we lean on the PRIMA data for that. Or if patients started with bevacizumab and you decided against a PARP inhibitor for many reasons, such as hematological toxicity, they could just simply continue with bevacizumab based on the GOG 218 and the ICON 7 data. Now, thirdly, if the patient was a BRCA wild type and was HRD negative, well, maintenance therapy could include niraparib as part of the PRIMA data because it was inclusive of all patients, as we'll recall. You could continue the Bev because you started with the Bev as maintenance therapy, and this would be based on GOG 218 and ICON 7. Or you could choose at that one point in time, if they were BRCA wild type and HRD negative, to stop the Bev and just continue with observation. Okay, so these are the choices, and this is how we build a clinical platform, a clinical pathway for patients with ovarian cancer. Now, take contrast if you decided that you were not going to start off with bevacizumab, okay? Once again, we ask similar questions. If the patient had a BRCA mutation, germline or somatic, what are our therapy choices? Olaparib or niraparib, based on SOLO-1 and PRIMA, respectively. If they had a BRCA wild type or HRD positive, the choices were niraparib, based on PRIMA, or Bev, based on 218 and ICON 7. And if the patient had a was wild type for BRCA and was HRD negative, the choices would be niraparib based on PRIMA, Bev, if you wanted to just use as Bev as maintenance, or simply observation. So again, we start off with understanding the literature, understanding what our choices are at time 0, understanding the genomic alterations, and understanding which drug would suit the patient the best. So how do you execute a successful pathway? You start off with the patient population. You understand the histology. Most patients in the ovarian cancer trials were either high-grade serous or endometrioid. You do genomic testing. We mentioned this repeatedly, how very important this was for this type of pathway. You understand the literature, which we spent a good portion of time executing the literature. And then you create an algorithm and you see it through a patient's as well as a clinician's lens. That is how you successfully execute a pathway, in this case for ovarian cancer. So we've shared with you a great deal of data. I hope that this was interesting and informative. And I just want to thank you all for patients who actually spend their time taking care of patients with ovarian cancer. So thank you and have a good day. Thank you for listening.
Hello again. We are here with Dr. Campos to answer some audience questions. Susanna, we have a couple of questions from the audience. The first one is, if a patient has had maintenance therapy with a PARP inhibitor in initial management, is there a role for repeat PARP inhibitors if there is a recurrence 30 months later? That's a platinum-sensitive diagnosis.
I think that's an excellent question. And this often comes up because as we start to use the PARP inhibitors more frequently as maintenance therapy in the upfront setting, what is the role of the PARPs if the patient has already been exposed to the PARP? I think it's easy to say that if a patient progresses through a PARP during first-line therapy, I would not necessarily utilize a PARP again. This question is actually the subject of a clinical trial, the AUREA or ORIO trial, and that particular trial is actually going to look specifically at PARP after PARP. So we don't really know the answer at that point in time. Some individuals will extrapolate from some of the recent data on SOLO-2. SOLO-2 actually did show us quite an advantage in terms of overall survival with the PARP inhibitors, which is great. However, of course, these are individuals that did not receive a PARP initially, but it also showed us an increase in MDS, which was a little bit concerning. So, and having actually spoken about this issue this week with some other colleagues from different institutions, most individuals would not necessarily gravitate back to a PARP inhibitor in a platinum-sensitive recurrent ovarian cancer. In that group, they may lean more towards, for example, a GOG 213 regimen with carboplatin taxol Avastin if there's no contraindication, or the AGO study, which would be the carbogemcitabine Avastin, and use Avastin or bevacizumab as maintenance therapy. I do think it's a really good question, especially as this question highlights the recurrence was 30 months later. And if the patient really did have such a robust experience, Why would you not want to replicate that again? The question is, as the individual gets more and more treatment, the risk of MDS may increase. So we don't really know the answer at this point in time. So at this point, the ASCO guidelines really suggest that perhaps the answer is no. I do think some of us do it in clinical practice if a patient is really out there. But I think most people would lean towards, in the platinum-sensitive recurrent ovarian cancer, maybe to lean as maintenance therapy on the bevacizumab if there's no contraindication.
Great, thank you very much. Another question that's come in is there any mechanism difference in niraparib that it can have an advantage in non-BRCA and HRD patients?
So it's a very good question, and this really leans on the PRIMA data, and it's quite important just to kind of go back to the PRIMA data and talk about how very different this was from, for example, SOLO-1. SOLO-1 was basically just your germline and somatic mutation carriers, but the PRIMA really included all of these individuals. It included a BRCA mutations, included HRD positive or HRD proficient tumors. At this point in time, I think I can understand the mechanism of action, maybe perhaps not as being not as different if a person was BRCA mutation or HRD deficient. In a person who's HRD proficient, why did we see a progression-free survival benefit? I don't think anybody knows. They're looking at other mechanisms upon which a PARP can actually do that, but no one really knows why you're actually going to get a response in those individuals. It is very much like, in the platinum-sensitive recurrent ovarian cancer, when you got NOVA, when you got SOLO-19 and ARIO-3, where you basically did have a response, even in patients that were not BRCA, BRCA mutation carriers or HRD, you got a response. But the question is why? And having spoken to some of the companies that are looking into this, they're going back into the basic science and trying to understand why is this the case. So we don't know. We absolutely don't know at this point in time. But we know that the PRIMA did show a progression-free survival benefit in the BRCA mutation patients, in the HRD patients, and the proficient patients. And I think one thing to really lean on this particular study is to really look at the eligibility criteria of this study. These were patients whose clinical course was hampered by a lot of volume of disease. This is very different than other studies, so it showed a benefit even in patients with a heavy burden of disease, because in order to get to this trial, you had to have residual disease after surgery, which is in marked contrast to some of the other studies. So it's clearly a different. The results may be the same, but the eligibility criteria really kind of highlights some very important points.
Great, thank you very much. Another question has come in, somewhat related, it would seem. How do you clinically differentiate between SOLO-1 and PRIMA data, given the use of PARP inhibitors in both?
I think that's a very good question. I think these are both very, very solid studies, but as I kind of alluded to in the previous question, which is a great segue into this one, is that there are differences in eligibility criteria. So SOLO-1 really studied only germline and somatic mutation carriers. It is a beautiful study, and if you looked at some of the data, there's no banana curve there. You know what I mean? Those curves still separate after a great deal of time. It's a very encouraging data. But SOLO-1, the FDA has approved SOLO-1 really only for germline and somatic carriers. So we still have a great deal of other patients that are HRD positive, patients that are, even proficient patients. And there's been a benefit showed in the PRIMA data. So, in my practice, I think when I have a germline or somatic mutation carrier, my choices are going to be olaparib or they're going to be niraparib. A whole different story on PAOLA. We could talk about that also separately. I'm going to use either the olaparib or the niraparib in those groups of individuals. And I think how you choose these drugs, these drugs are equally as good. It's just that you have to understand the patient. If a patient has a history of volatile hypertension, perhaps niraparib is not a good choice. Meanwhile, if they don't, they're both equally. If they don't, then they both are equally good. So I think it's just important to understand your patient population. What are their comorbidities? What did they experience during those first induction phases of the chemotherapy? That helps guide in terms of SOLO-1 or PRIMA. However, PRIMA does have that HRD positive label, and it certainly has the HRD proficient label. So in my opinion, if a patient is disease-free after surgery, is a germline mutation carrier, I go to Solo 1. If the patient is, had a heavy burden of disease, had disease after surgery, is HRD positive or maybe HRD proficient, I will go to niraparib. And with niraparib, I'm cognizant of the fact about platelets and about weight issues, because that's extremely important in terms of dosing, like we discussed. So, but these are both very valuable studies, and we haven't even got into PAOLA, so which is completely
Great, thank you so much. Susanna, thank you very much for your comments.